Okay, everyone, we are going to go ahead and get started. Please let us know in the chat if you cannot hear us, if we're having audio issues or anything like that. But I'm excited to bring on Dr. Leona Oakes today to talk about mental health and autism spectrum disorder. Thank you all for being here. I'm going to start by introducing Leona, and then I'm going to go ahead and give a brief overview of the Regional Center for Autism Spectrum Disorders, who we are, and the region that we represent, and then we will go right into the presentation. So if you have any questions during the presentation, please put them in the chat box that you can find by hovering up on the top of Zoom and hitting the triple buttons, and it should pull up the chat option for you. And so you can go ahead and you can send a question to everyone, or you can send a question just to us. But we would love to hear your questions, and we will make sure to have lots of time for Q&A at the end. So Leona Oakes is a licensed psychologist in the Department of Neuroscience and in the Division of Transitional Care Medicine at the University of Rochester Medical Center. She is a graduate of the University of Rochester, and she completed her clinical internship at the Office of Mental Health, Hutchings Psychiatric Center. Her postdoctoral fellowship was through the Division of Developmental and Behavioral Pediatrics here at the University of Rochester Medical Center. And Dr. Oakes does research with individuals with autism spectrum disorder across the lifespan, studying how to best assess individuals' strengths and needs and how to use assessment to inform and evaluate interventions. At the Complex Care Center, she sees patients with pediatric onset illnesses, so individuals who are diagnosed as they were a pediatric patient, and with mental health concerns. And she has a special interest in the assessment and treatment of individuals with multiple diagnoses with developmental disability and psychiatric disorder. So we're so grateful to have her here today, and I'm just going to make sure you all can see us. Okay, so there we go. Okay, trying to find us. Anywho, I'm going to go ahead and move to the next slide, which goes over the Regional Center for Autism Spectrum Disorder. As you can see here, we represent the blue region. So we cover, let's see, 12 counties. It recently changed, which is why I couldn't remember off the top of my head. So we cover 12 counties, and the Regional Center is a partnership of 7 university-affiliated programs across New York State with an overall goal of identifying, disseminating, and assisting in the implementation of evidence-based practices to improve services and outcomes for individuals with autism spectrum disorder. So the approach is to allow resources to be available to families and professionals in New York State that have not had access to cost-effective services in the past. And each of these 7 regions that you can see pictured here provide high-quality autism spectrum resources, which may look different depending on the region, to make them available to families, individuals with autism, and professionals. So let's go ahead and jump right on into our presentation, and I will turn it over to Leona Oakes. Dr. Oakes.
Welcome, and thank you everyone for coming. As Jen specified, one of the things I really want to do today is leave lots of time for questions and answers. So please do submit any questions you have. I had the idea that many people might be signing on saying, oh man, I really hope she talks about this. And so first I'll go over what I'm definitely going to talk about, but then I definitely want to cover things that you're most interested in, of course. So first we're going to talk about how to understand mental health concerns within individuals with ASD, what makes them sometimes more challenging to treat, when we need different approaches, what we need to be careful of. That will dive into special considerations when treating this population. We'll talk about how to promote mental health hygiene in individuals with autism spectrum disorder, both some preventative work on helping to prevent them from developing mental illness, and then what to do if they do have problems. I'll dive in specifically for some considerations for professionals, but I do want this to be a webinar that's useful for everyone, so I won't go into too much detail unless that's a question that comes up a lot. And then, as I said, I want to leave a good chunk of time for questions and answers. So we're going to talk about how do we understand mental health specifically in ASD. And first, I just want to outline that I'm going to be talking about symptoms of what we consider mental illness, as well as specific diagnoses. So, I might say with an anxiety disorder or with a mood disorder, but overall what we're talking about is when they experience anxiety, when they experience depression. And part of the reason for that is many individuals on the spectrum won't meet the criteria for a major depressive disorder episode or a specific anxiety disorder, but that doesn't mean that their level of sadness or their level of anxiety isn't a problem in their day-to-day life and isn't interfering with their functioning. So a lot of times that can be one of the challenges to treating them, is that there isn't an appropriate diagnosis, but they need treatment and they need help. So we're going to be talking more overall about those topics and worried a little bit less about diagnosis. But of course, if questions come up about that, we can dive into it. So today I'm really going to focus on anxiety, depression, anger, and irritability. I do want to acknowledge that attention deficit hyperactivity disorder is the most common co-occurring mental illness, but ADHD and executive functioning is a whole nother webinar on how that affects autism. So that's going to be a different talk and not today. So when we think about concerns, anxiety is one of the ones that pops up the most. And so we want to think about what that looks like. So most recent studies evaluate that about 40% of children and adolescents with ASD also have another anxiety disorder diagnosed, like generalized anxiety, specific phobia, separation anxiety, things like that. About 76% of adults with high-functioning autism report having anxiety of some sort. And we expect similar numbers with children, that even though 40% are actually getting a diagnosis, far more than that have difficulties with anxiety that just don't meet criteria for a specific diagnosis. So this is really prevalent in the population and something that we want to think about. Now, there are some ASD characteristics that are related to anxiety that make it so that they're less likely to have a specific diagnosis of anxiety, but more likely to have anxiety, right? So for example, they often have difficulty with social settings. So it makes sense that when we introduce them to social settings, they're going to be more anxious than your typical individual. Similarly to adapting to different situations. When we know that an individual likes the same routine and his normal order to things, asking them to adapt to different things can often elicit anxiety. Similar bounds go with the rigidity and the resistance to change. Transitions are hard, changes are hard. And so that's all going to be tied together with, there's just more opportunity to elicit the anxiety of individuals with autism than there often is for more typically developing individuals. The ASD also affects their presentation. And so we tend to think of anxiety as an internalizing disorder. We kind of picture, someone that is standing off in the corner, very quiet, very worried, very shy. With individuals with autism spectrum disorder, their anxiety can often be much more outward. You'll see perseverative questions about their worries. You might see scripting, either scripting things that comfort them because they're trying to cope with the anxiety, or scripting their worries over and over and over again. As much as rigidity may or may not be part of that individual's profile, they may be even more rigid when they're anxious because they want to control. And outbursts are not uncommon for individuals with autism. And it's often what we, see in terms of complete meltdowns where they really, really lose it and then feel terribly remorseful afterwards, or really show a lot of upset behavior that it happened. And in addition to the challenges of the fact that individuals with autism present their anxiety differently than neurotypical people, we also see that individuals with autism have their own unique aspects of anxiety. And it was recently called Atypical Anxiety by Kearns and his associates. And we see that they often have worries about changes in their very special, specific routines. We see a lot of worries about their intense preoccupations. So what that will often look like is caregivers telling me, well, we carry the iPad around everywhere because that's his main source of entertainment, But if it goes below 40%, it's going to be a meltdown if there isn't a charger. So that really intense worry about their few sources of pleasure or interest. They also tend to have unusual phobias, some of which can be sensory related, like an absolute terrified fear of water, where walking out in the rain is an unacceptable experience, to even more unusual things like the color yellow and things like that. Of course, we also see a lot of social discomfort and fearfulness without the fear of negative evaluation. So that's something that specifically applies to social anxiety, right? When we think of social anxiety in the neurotypical person, we think specifically of people that are worried about being evaluated in public speaking, while around other people. With individuals with autism spectrum disorder, they often meet all other criteria of social anxiety, but they don't hit that fear of negative evaluation. And part of that is because of their lack of perspective taking, their challenges with theory of mind. So they're not so much worried about what you're thinking, but they do know that they don't often get it right. And so they get really anxious about not getting it right over and over and over again. Another aspect of how they might present their anxiety is that, similar to other children, but this goes all the way into adulthood for individuals with anxiety, we'll often see and hear a lot of physical complaints from children on the spectrum that are anxious. Stomach aches, headaches, body aches and pains, things like that. And they tend to have less insight about their worries that they can vocalize. And part of that is because as soon as you start talking to them about what they may or may not be worried about, they feel worried, and then their communication really shuts down and their ability to share that insight. And so one of the biggest challenges is, how do we help them confront their worries when they have such a difficult time even feeling safe enough to talk about them and get through it? Now moving on into some of the details about depression. So again, about 10% of children and adolescents with ASD also have some type of mood disorder. And then 75% of adults with high functioning autism spectrum disorder report difficulty with depression and feelings of sadness and things like that. Again, they're not saying they've been diagnosed with a specific disorder, but they're acknowledging that they have difficulties with that. One important thing to think about when we think about depression and ASD is suicidal ideation. Individuals with autism spectrum disorder are much more likely to share suicidal ideation with others, to talk about it. And it's really hard to understand where that's coming from. Some of it is, of course, coming from high anxiety, feelings of sadness, and some of that. But we also know in the neurotypical population, when children and adults are feeling some suicidal ideation, there's a filter of, but I can't actually say that, but I can't actually talk about that. I can't just yell it. I don't really feel that way. I'm, just that upset. And individuals with autism tend to not have that filter. Now, of course, that is not to say that we shouldn't take suicidal ideation seriously in this population, but I think we need to look at the individual's intellectual level, how upset they were when they said it, what the circumstances were. It's definitely a cry for help, and that we need to help them in whatever feeling is eliciting that suicidal ideation, but we don't need to sort of call in the cavalry and treat it as much like a crisis situation as we might with someone that doesn't have autism spectrum disorder. Because again, we know the typical population will self-screen a lot and not say those things. For many individuals with autism, saying, oh, I can't stand it, I just want to die, is sort of the only way they have of telling people how serious it is, how upset they are. And then the flip side of that is, we do know impulsivity is a risk factor for attempting suicide and things like that. And our individuals with autism spectrum disorder do tend to be more impulsive. So again, you want to treat it carefully. You want to address whatever sad thing happened, whatever anxiety producing thing happened, whatever upsetting thing happened to elicit that suicidal ideation. But we don't want to jump right to, we have to go to the ER because they said this. You want to be able to address it calmly, with safe people, and really talk the individual through it, because again, that might just be the only way they have to share how upset they are. We'll go into more detail about how communication can really shut down when they're upset. Some more concerns when we think about depression in this population. There are some ASD characteristics that feed right into mood. They tend to have very limited interests, so they're a little bit more susceptible to things like anhedonia, because when you only have one or two extreme interests, if those are limited, then you don't have as many things to get enjoyment out of. Similarly, they tend to be more socially isolated than their peers. Now, individuals with autism vary widely on how much social interaction they actually want and feel like they need, but nevertheless, we know that social isolation is a risk factor for depression, and especially for those children and adults with autism that want to have friends but don't quite connect to them. Social isolation can really be a huge impact on their mood. Similarly, we want to think about how their perseverative thoughts can interfere with moving on after something sad has happened, especially with grieving. And black and white thinking tends to be something individuals with autism do. They tend to be very concrete and have things want to fit into categories and boxes. And so that can be really difficult when it comes to mood management. If something's bad once, it's always going to be bad. If this was a bad thing, it's always going to be bad, rather than seeing the shades of gray and how things might be improved. They're also going to have some changes in depression presentation. So anyone that works with children knows that depression in children can look as tearful as it does irritable, that children will often present with both. For individuals with autism spectrum disorder, that continues throughout the lifespan. So adults with autism spectrum disorder may have depression that presents much more as intense irritability than it does necessarily as tearfulness. Their episodes of tearfulness and irritability can often last much less time than someone who we think of as going through a typical major depressive episode. So that's again where sadness might be a significant problem, have a very big effect on their functioning, but they don't meet criteria for a major depressive episode because they're not sad for the majority of the day, most days a week, for a set period of time. It might be in a period of extremely intense sadness for 2 hours every day when they get home from school, but weekends are great. And so that doesn't mean we don't need to address that sadness during the week. It just unfortunately ties our hands for the disorder. So part of this presentation is also about being comfortable treating the mental illness issues, even if they don't reach that level of disorder. And that's good preventative work too. Again, individuals with autism, you want to look out for increases in isolation when they feel sad. Losing their interest is also a very big and important red flag for them. And then again, just like we would expect of other people having a depressive episode, you'll often see sleep changes, you'll often see eating changes, but we want to be aware of the individual's baseline. So many individuals with autism have odd or different sleep schedules. So again, we're looking for a change. Same thing, a lot of our fellows are very picky eaters, super selective, or they will stuff any moment they can. So we're looking at changes in those things. One thing that's really notable for our kids is that things that they used to take comfort in and really enjoy, all of a sudden they're going to be unable to find comfort and be really restless. And so that's something we want to think about. Lastly, I want to talk about anger and irritability and how that often affects our population. Many individuals with autism, from kids to adults, talk about how that's it. They're just angry and they can't help it, and it comes out of nowhere, and and then it's done. And so that 0 to 100 is a common theme for this population, that they either aren't sharing the insight that maybe they're a little bit grumpy and then something's setting them off, or that's just how they go. It's 0 to 100. But again, with a lot of our fellows, we see outbursts that are huge and disruptive and might consist of self-injury towards themselves, might consist of aggression towards others, but then they're really remorseful afterwards, especially if they've been aggressive towards others. And so we're really seeing a complete lack of control in these episodes. This is where our fellows tend to especially lose any sort of insight. They have a very hard time identifying triggers. When they do identify triggers, they often say, well, he did this, so I did that, as it, and really believing and feeling like that is the next step. That's the only step they could have taken. And so part of that is their social reasoning and their problem-solving abilities in the moment. I think another big part of that is how intense their emotions can be, that when someone hurts their feelings, feels as much an attack on them as a physical attack. And so physically attacking back is the next thing they do. And so that's where some more social skills work can be done there. But overall, we see a complete lack of control when they're feeling very angry, and that irritability goes through the roof. Now, I do want to focus in on the fact that while autism spectrum disorder is a developmental condition, a lot of the core features of autism and the diagnostic criteria we use just lend them to be much more vulnerable to mental illness, and why it's so important to do both preventative work with them and to address issues as soon as you see them. So when we think about that core feature, that individuals with autism are partly defined by their deficits in social emotional reciprocity, what does that mean? That means they have impaired processing of other people's emotions and reactions. So that's going to make repeated social failures happen. And for individuals on the spectrum that want to bond with a lot of their peers, that's going to be really hurtful. And that's where we'll see that higher propensity towards depression and anxiety and things like that. When we look at deficits in nonverbal communicative behaviors used for social interactions, what that means is that there's poor communication of emotions. Both the individual with autism's ability to communicate their emotion to other people and their ability to understand what people are trying to communicate about their emotions. So they're both having a hard time showing you, telling you that they're scared and nervous and upset. And when you're scared and nervous and upset, they're not understanding it. So when we have repeated misunderstandings, that means they're not learning to manage their emotions because when they're young, we're not able to dive in and help them manage it. They're not seeing how other people manage their emotions, so they're not really soaking in that social modeling of what you do. And then even when they're trying to convey their emotions, they're not doing it the way a neurotypical person will do it, so we sometimes miss it. When we think about the deficits in developing, maintaining, and understanding relationships, what that means is that there's going to be some social awkwardness that goes along with making friends, even relating to family members. That leads them much, much, much more vulnerable to bullying from peers, and even from adults that are just sort of going on the assumption that, well, since he doesn't do this, then that's not something that he's interested in at all. And they often end up being more isolated because sort of, well, he doesn't reach out, so he doesn't want to be with his peers. But that's not an assumption we can make with individuals with autism, right? A lot of times they're not reaching out because they don't know how to reach out, or they've reached out the wrong way and they've been rejected. And so we can't make those kinds of assumptions, and we've really got to be aware of what's going on for them. When we look at the restricted and rigid behaviors sort of category of inclusion criteria for diagnosis, we know that many individuals on the spectrum engage in stereotyped movements or use of objects, stereotyped speech, and that of course creates a lot of stigma around them and around their abilities. And we have a wide range of awareness from our individuals of autism spectrum disorder. Some people have no idea that people look at them differently and don't care if they did know it. Other individuals with autism spectrum disorder really want to be able to fit in, really want to be included. So when their peers or adults in the community look at them funny because they're doing a stereotyped movement that makes them happy, that's really hurtful and creates that high stigma. They also are more likely to have an insistence on sameness, the inflexibility, those rituals. So that means that they just have a general lack of exposure to new things, to changes, and that prevents all of those things being challenges now. They also have a lot of difficulty problem solving. If you do the same thing the same way every single time, you're not using your brain to think flexibly and to think differently. So then when you do come across problems and stressors, they're that much more difficult to handle and to cope with. As we mentioned before, individuals on the spectrum tend to have highly restricted interests, very fixated interests. If they only have one or two extreme interests, that can lead them to be very vulnerable to anhedonia when one or those two interests drop, or they're limited because they've become too fixated on them or too limiting. Again, that can also lead to social isolation. We see this a lot in our young adults and well into middle-aged adulthood in autism spectrum disorder, that because their interests tend to be solitary, they then don't have that ability to find other peers like them. Or they don't know how to go about doing that. Or they're only online relationships, which can be real and valid friendships, but they're not someone to go out with on a Saturday night, and they're not a way to meet new people around them. Lastly, we do need to think about how their differences in sensory processing affect their day-to-day life. And that can be for oversensitive people and for undersensitive people. Many individuals on the spectrum go through their life every day just feeling some sort of physical discomfort because they have to wear clothes in public, or their job requires this kind of uniform, or the lights are always too bright, but they've got to go to Wegmans to go food shopping. And so that's something where we need to keep in mind that sometimes their baseline overall is just a little bit more irritated than everyone else, because that sensory processing means they're always a little bit uncomfortable. So they might have a shorter fuse and be a little bit more vulnerable to stress and things like that. All right, some important considerations for working with this population. So in general, when you are working with an individual with autism spectrum disorder that has difficulty with anxiety or depression or anger, you want to keep in mind how difficult it can be for them to share emotional experiences and insights. Now, I think it's important to reflect on ourselves, right? When we get very, very angry, it is normal in the typical population to have a very hard time putting that anger into words in an appropriate way, right? That's why arguments happen, is because individuals in the argument keep shouting at each other without listening to what the other person is saying and without thinking a whole lot about what they're saying themselves, right? That's how we end up saying things that are hurtful in the middle of a heated moment. So for individuals with autism that already have social and emotional communication deficits, that's even more exaggerated for them when they're in an emotional situation and when they're trying to share some kind of insight about what's going on for them. So a lot of times when I'm in therapy with individuals that are extremely verbal, very high intelligence, if I ask them what they're worried about, they still can't put it into words. And so we need to really keep in mind how much more difficult that's going to be and to that. Again, we have a tendency towards outward behaviors. And so that's where a lot of times individuals with autism will be accused of being obstinate on purpose, being oppositional, because he knows it gets a rise out of me, or that kind of thing. Or if he's anxious, why is he throwing a fit? Anxious kids don't do that. Individuals with autism, because they have difficulty with emotion regulation in general, their emotions are going to go outward. They're not going to be able to hold them in. And again, they might also focus on physical symptoms. And sometimes that's the best way to get them to start talking about it. Rather than, all right, when did you first start getting nervous? All right, what's the first feeling in your body that relates to nervousness? Well, my tummy hurt early that morning. Okay, maybe that tummy, maybe your tummy hurting is a way of your body saying, I'm nervous, I'm worried about it. Did it get worse? Yeah, my stomach really hurt right before the math test. Okay. Do you think that was maybe a sign that you were super anxious because the math test was about to happen? That kind of thing. Now, there's also a lot of cautions to go into working with this population again. I think especially when we're working with lower functioning individuals, specifically with individuals that have less verbal speech, there is a huge tendency to interpret what they're doing without actually checking in on what that means for that individual. So this is where I'll see adult caretakers that say, well, her whole life she's done this, rubbing her fingers thing, so she must be anxious, And I say, well, if she's done it her whole life and she's done it while doing her favorite thing in the whole world, is that really anxiety? Or maybe that's just a repetitive movement and we're over-interpreting. If it is something that she's doing to calm herself because she's anxious, we're going to see it in a different way. And we want to really monitor that kind of thing. Now for the next topic. Rigid and repetitive behaviors are not obsessive compulsive disorder or OCD. I see this term thrown around a lot for our individuals with autism. Oh my goodness, he's so OCD. Every time he gets something on his hands, he's got to wash them immediately. That's not OCD. That's probably a component of their sensory difference. They don't like the feeling of whatever is on their hands, so they go to the bathroom and they wash it off. And that's not necessarily a problem unless every little thing that gets on their hand happens over and over again, so they're spending more time in the bathroom than they are working at their job, for example. Then it's a problem. If it's just he doesn't like sticky hands, that's not a problem. And we don't need to over-label it and over-pathologize it. Individuals with autism are perseverative. They have repetitive behaviors. They have intensive interests. It's not a true compulsion unless there's anxiety tied to it. Now, that's not to say it's easy to pull it apart, but we don't want to jump right to OCD because it looks like it might be anxiety. As I mentioned at the beginning, individuals with autism will often do repetitive things as a self-soothing method. So yeah, they might do it when they're anxious, but if you don't allow them to do it, their anxiety might get worse because that's how they're calming themselves, not because of it's a compulsive behavior. And that's where in my own personal practice, you have to dive in with those questions. I'll ask individuals, your community hub worker noticed that when you're walking through the store, you're kind of flapping like this. What's going on, buddy? Oh, it's just something I like to do. So that's a repetitive behavior. It's not a compulsive behavior he's doing because he's nervous in the store. It's not something we need to stop. Typically, individuals with autism will talk about their repetitive and rigid behaviors and stereotype behaviors of, it's just the way I like to do it. It makes me feel better. I don't know, it makes me happy. When you ask them about why they're doing those things, whereas we know people with OCD, when they're engaging in compulsive behaviors, we get feedback like, well, I have to do it because once I do it, the anxiety about doing it goes away. They express relief when it's over rather than comfort or pleasure in the behavior itself. Now, of course, that's much more difficult when an individual is less verbal or less able to talk about their feelings, but we don't want to jump right to OCD. Similarly, we don't want to over-pathologize our individuals with autism, and we don't want to force neurotypical behavior on them. We don't want to say something's a problem just because it's different. We want to be very protective of their personhood, and we want to make sure that we're not forcing them to be more like their neurotypical peers in ways that aren't disruptive to their functioning. So if Bobby likes to keep a schedule and follow a schedule, that's great. He can keep it. We need to, of course, make sure that Bobby can be flexible within his schedule so that if there's an emergency, he can switch something out. But just being rigid about that schedule isn't something we need to change if he can cope with things that come up. And that's where, again, you want to be aware, you want to be understanding of the individual nature of each of these individuals. Now we're going to talk about mental health hygiene. And this both speaks to what we can do preventatively, what we can teach young children with autism, or really any age of the person you're working with right now. How do you start working on mental health hygiene? And then how do you build it up for individuals that are having difficulty with depression and anxiety? So the foundation for all mental health is emotion recognition and labeling. And this is where, again, because of the characteristics of autism spectrum disorder, our fellows are just starting at a really different place than the neurotypical population. They're not as aware of other people's feelings. They're not able to understand and take that perspective to infer where they're coming from and what they're going and where they're going. And so we need to show them that. One of the ways we work on emotion recognition is really breaking emotion down into all the little pieces. So we want to talk about what triggers an emotion. What's something that makes you feel happy? What's something that makes you feel angry, sad, nervous, and so on? What are the body clues that you feel that way? Does your heart race when you feel really, really nervous? Does your body get hot when you feel angry? Does your body feel light and like there's bubbles in it when you're happy? You want to help them communicate those bodily feelings that they are so good at tending to and acknowledging, and then relate that to the emotion. You want to go into thinking clues. Oh my goodness, what are you thinking when you're feeling happy? Are you thinking, this is so great, I hope this keeps going, I want this to happen all the time? When you're angry, what are you thinking then? Really conveying the idea that emotions have a purpose, right? We get angry about something because it's bad for us and it shouldn't happen again, and we need to protect ourselves from it, right? Anger has a message. Anger in itself isn't good or bad. It's what we do based on our anger that can be positive or negative. So having that angry thought of, I'm angry that person did that, is okay to have. We need to then look at our behavior clues, right? If we're yelling and raising our voice and stomping, all right, now that's a clue that our anger is starting to sway us too much, maybe. What's a better behavior to have when we're angry? What are some early signs of anger so that we can bring it down before it gets to be too much? And overall, you want to use consistent terms. A lot of times that term can be the wrong term, quote unquote. For example, I have a young man that I work with who hears voices, but he would never say, well, the voices were really bothering me and that's why I started pacing. He says, I was feeling really anxious and that's why I started pacing. So in our session, we talk about feeling more or less anxious, and that's fine because those are the words that he identifies with, that he understands in regards to his feelings. And we get the whole team on board with that. So when I talk to his psychiatrist and his doctor, I'll say, he talked about feeling more anxious. We know that that means the voices might have gotten a little bit louder or a little bit meaner or a little bit more difficult to deal with. So what can we do about that? How can we help him cope with that? It doesn't matter that he doesn't use the words as long as we all know what they mean and he's using it to ask for help. Visuals for emotions. Even for people that have beautiful, fluent language, visuals help tremendously when they're learning about emotions. And this will be a little bit of experimentation on what works best for the individuals. Some individuals really like photographs of their family members doing these emotion faces, photographs of themselves doing it. Some individuals that, especially those that get so angry or so anxious and they have these huge meltdowns that they can barely remember, video can sometimes be really helpful for them where they see what it looks like and they can look back on it and say like, oh my goodness, that was the first sign I needed to calm down. Okay, I want to be more aware of that. Again, you're always approaching it with, this isn't a video to show you how bad you are, how badly you did. This is a video because you can't remember. You get so upset, you can't remember what happened. I want to show you what happened so we can fix it, so we can help. And then a lot of individuals with autism just do better with cartoons or emoticons of emotions, as I have displayed there on screen. The big exaggerated facial features really help them kind of click in and get to know it. And again, when we're thinking about the impaired communication, keeping a little laminated sheet of emotions so that when you get upset, you can just pull it out and point to it to ask for help. That is 1,000 times easier than having to look at someone and say, I'm anxious. I know it might not feel like a huge difference to a neurotypical person or to a person on the spectrum that is more verbal, but for so many people, even the verbal individuals, that's a lot easier. Now going into coping skills. So hopefully we've brought our individual up to, they know what signs mean in their body, they know how to recognize emotions they have a safe way to tell us that emotion, to let us know what's going on. All right, so now that they've communicated that they're having a strong emotion that they want help dealing with, or that they know they need to do something about, right? Because ideally we're also working towards independence in emotion management. What's a coping skill to teach? The first coping skill I always teach is deep breathing. There are a few special tips and tricks though. So one is, again, with individuals with autism, you often need to be a little more creative with presentation. You want to locate it in the body. Deep breathing comes from your stomach or your belly. Put your hands there. You need to feel that belly going in and out. I often exaggerate it in session. I'll put my hand in my chest and I'll show them, look, this is anxious breathing, right? No one feels better when they do that, but if I breathe in through my belly and my hand moves on my belly, that shows that I'm breathing calmly. Explain how it works in their body. When you breathe deeply through your belly, your heart rate literally comes down if it's been up. Your blood pressure literally goes down if it's been up. It's an amazing thing that breathing, something we can force our body to change and do differently, controls other things that we don't think of as something we can change, like our heart rate and our blood pressure. With different individuals, sometimes using bubbles helps so that they can really visualize that slow, calm breath leaving their body. A lot of individuals with autism spectrum disorder, if you have them focus on their breath, they're going to go, see, I'm breathing. And no, I want you to breathe as slow as possible, as long as possible out. Some individuals do really well, again, when they can visualize it. So having them lay down on a couch, on their bed, put something on their belly. For kids, a beloved stuffed animal, make that stuffed animal go up and down super slowly, like they're on an elevator on your belly, can be a great way to do it. I also use character examples. You know, if Star Wars is a fixated interest, great. We're going to breathe like Darth Vader. We're going to make silly noises and we're going to breathe in and out over and over again. Whatever works for them. But again, use visuals, use things that they can see, use things that they can feel. One big thing I often hear from individuals, especially adults in my practice, is I tried deep breathing, it doesn't work for me. So we're going to go into some tips and tricks about all coping skills, but especially deep breathing in a minute. We also want to embrace that individuals with autism spectrum disorder have the sensory differences that sometimes can be a problem and lead to discomfort in their everyday world, but it can also be a great source of ways to soothe them physically. And so a lot of individuals on the spectrum really benefit from doing something sensory when they're starting to feel overwhelmed with anxiety, with anger, with sadness. So that can be anything from squishy stress balls, and they make all kinds of stress balls. And so really go wild. I encourage, families to go into Five Below or Walmart or a store like that around you that just has a lot and try a few things out in store. I usually have a box in session with me where I say, let's try things out. Putties and slimes are really great ones for that sensory component. Water play is okay. And that's even for adults. A lot of my adults on the spectrum find taking a hot shower or a cold shower after a frustrating day to really help them calm down. And it's part of a natural human response that when you get water on your face, you start to breathe slower and calm down. So I'll ask individuals, well, you know what? If you're anxious, what about ducking into a bathroom, washing your hands, splashing some water on your face, getting that little bit of physicality there. A lot of individuals on the spectrum also respond really well to massage tools, like massage bars that they can rub on their own back, on their legs, on their arms when they're feeling stressed. We know that pressure, like weighted blankets, can be super helpful too. One thing I always try to have individuals find, though, is a sensory-based calming tool that fits in a pocket so that they can bring it with them everywhere. That idea of everyone needs to cope, everyone needs that with them is great. That's the other reason I focus first on deep breathing. I always tease them that you've got your lungs with you everywhere you go. And especially for individuals that are more self-conscious about not being perceived as different, everybody has to breathe. And you know what? If you're doing deep breathing, it actually means you're breathing calmer, more subtly, more relaxed. And so you're less likely to attract unwanted attention when you're doing nice deep breathing. Another tool I rely on heavily are positive thinking scripts. So these are very similar to social stories. But what we're doing for an individual with autism is giving them positive thoughts to replace any of those perceptive negative thoughts that might be going there. And so in these, I usually have them written out with pictures, and I encourage people to review them as often as possible, at least a couple times a day. So you want to explain the problem. Lily gets nervous every time she has to do something different. You want to provide some rationale. But we have to do things differently to learn and change. The world isn't the kind of place where the same thing happens over and over again. You want to identify the emotion. Change and differences make me feel really nervous. I get butterflies in my stomach and my heart starts beating. I feel scared. I think I don't want this. You want to list some coping skills. When I feel nervous like that, I can do my bubble breathing. I can grab my squishy ball and squish it as hard as I can. And then you want to provide that positive self-talk. I can tell myself, I will be okay. Changes are okay. I'm still safe. I can do this. That kind of thing. Overall, with coping skills, You want to practice, practice, practice. If you are a practitioner, you know that the hour a week, every other week is not going to have the kind of impact as practicing every single day. You know, we know that neurotypical individuals have a hard time generalizing what they learn in sessions to their everyday life. So do individuals with autism spectrum disorder. They might come into your office and do a great job calming down there, but it's not generalizing to the real world, to school, to home. And so this is where it's on the professional to convey. Everything we do here has to be done at home, has to be done at school. This can't be a box where only these coping skills live. We've got to push it out of the box. We've got to practice it at home. And one thing, again, we need to keep in mind is we can't ask someone to do a coping skill only when they're upset. That coping skill has to be built up. It has to be something that's easy for the individual to do. It has to be something that the individual associates with feeling better, feeling calm. And so that's where I'll get that story. Oh, I've tried deep breathing when I'm angry. It doesn't work. And then I ask, well, did you only try it when you were angry? Well, yeah, I get upset and then I do the deep breathing like my therapist told me to, and it doesn't work. And I said, well, yeah, of course not. You can't do anything you only do when you're upset. That doesn't work at all. You're absolutely right. That's why it didn't work. You need to practice deep breathing when you're relaxed. So maybe in the morning when your alarm goes off and you're laying in bed and just relaxing, that's when you need to practice deep breathing for a few minutes because you're feeling nice and cozy in your bed. Right before bed, you want to practice deep breathing and really stretch out, feel relaxed. Where's your favorite place in the world? Oh, your reading corner. Let's practice deep breathing in your reading corner. I want you to be really, really good at it so that then when I ask you to do it when you're a little bit upset, it's easy because you do it all the time and your body associates it with feeling calm. So as soon as you do it, your body goes, oh yeah, this is what I do that helps me relax. I'm gonna calm down now. Same thing with the squishy ball, same thing with that positivity script. You want to read it over and over and over again at relaxing times so that when you take it out when at the very first sign of feeling upset, it's something that's doable, it's something that is familiar, it's something that already feels good. If we're thinking about replacing challenging behaviors with positive coping skills, we want to make sure that that coping skill is easily requested and available. That's why I talk about what can you put in your pocket. That's why I say, you know, your lungs are always with you. So deep breathing is always with you. You want to make it more easily available than blowing your top. Also, if you're asking someone that's getting upset to be patient and wait while I go get your coping thing, that's another thing they have to deal with. So you want to make sure that coping things are always easily available. That's where it can be handy to have a little bag of supplies with you wherever you go. And then, of course, you want to evaluate their use. Coping skills are going to change throughout the lifespan. They're going to go in and out of fashion as the individual is adapting and growing. So you want to make sure that you are keeping up to date with what is and is not working. And you want to celebrate the smallest steps. You know what? Yeah, the deep breathing didn't prevent all the yelling and screaming, but maybe it delayed it for a minute or two so that other people could come and help, or you could move to a safe space where it was okay to yell and scream all you wanted. Or maybe the deep breathing didn't stop it, but instead of yelling and screaming for an hour and that ruining the rest of your day, you yelled and screamed for 5 minutes and then you were able to get back to work and then you were okay. So you want to celebrate those little victories and you want to expect small steps and work up towards the beginning. You know, I have an individual where anxiety was often expressed by chewing his poor little fingernails all the way down to the bed. We started with one fingernail. All right, which fingernail are you not going to bite this week? All right, let's measure it. If that fingernail isn't bit next week, his favorite color was green. I'm going to paint that fingernail green. And we'll keep moving on to fingernail to celebrate. Then instead of biting your fingers, you're using your chewy tube when you get nervous, that kind of thing. Again, in the theme of respecting the personhood of the individual with autism, you really want to get their buy-in to understanding why these coping skills are important, why you need to address this change. And I think, again, but especially if the person with autism spectrum disorder is aware of their diagnosis, aware of how they're different, when someone else encourages them to seek treatment or help or change their behavior, it can often feel like an attack on them. Well, you just don't like it because you don't like it when I yell. And it's, they don't always see how it affects them or limits them. So one of the ways you can help is by first modeling your process. A lot of times I remind my patients, you know what? Everyone uses coping skills. They just don't call them that. But when your mom hears that her favorite show got canceled and she can't go out to the play she wanted to go to that night, she feels really sad and disappointed, and she has to do something to feel better. And I'll turn, Mom, what do you do to feel better when you feel really sad and disappointed? And she might say, actually, I get a hug. Great. See, just like mom needs a hug when she feels upset, you might need something to do to feel upset. What are we going to do to help you feel better? And if you're an adult with a young child, you want to model it. I always use the example because, driving can be a very frustrating situation. If a car cuts me off and I end up going at the wheel while I'm driving, then I'll say out loud, ooh, that made me really mad. I need to take some deep breaths and calm down so I can be a safe driver. And I'm going to do that out loud for the benefit of the child in the car, for me to see that I'm modeling behavior, positive emotional coping behavior. And I think, with parents, that's especially difficult. A lot of parents will tell me, well, I don't want to cry in front of my child. I don't want to get upset in front of my child. And you're absolutely right that you don't want to get upset about your child in front of your child, but you do want to model other emotional processing about other things that trigger your feelings around them, because they need to see that this is something everyone does. That helps their buy-in. Oh, this is just part of growing up. This is just part of being a human on this earth, is processing emotions and dealing with them. When you're getting buy-in from adolescents, teenagers, adults, you want to really focus on the individual's goals. All right, what do you want in the end? I want to get my CDL. Okay, great. If you want to get your CDL, what are all the steps you need to do that? Okay, and they lay out, they need to, practice, they need to get their regular license first, blah, 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 all of those things. We need to go to school. Okay, what have been problems with school in the past? Well, sometimes I get really angry at my teachers and then I get in trouble. Okay, so we can't let that be a problem when you're in classes for your CDL. Do you think we should work on your anger so that you can keep working towards your CDL? Oh, okay, yeah, you're right, that probably interferes with it. Let's do it. And so you want to make sure that they understand that they don't need to process their emotions because it's a problem for everyone else. They need to process their emotions because it's a problem for them. For a lot of individuals with anxiety, where they have all of these behaviors that they have to do or can't do because it makes them anxious, I point out, you spend so much of your day feeling anxious and fixing it. What if you could feel happy during that time? What if you had more time to do your favorite activities instead of having to do things that made you feel better instead of being anxious? That's why we need to fix this, is so that you have more time to feel happy and enjoy the things you love, to accomplish the things you love. And so that's where we're identifying how anxiety, depression, anger, irritability are interfering with them reaching that goal. So they have the rationale for why this is so important. And then again, you want to provide immediate positive feedback and rewards. And by rewards, I mean praise, high fives, time spent doing their favorite things with their favorite people, just like anyone else. Now, a few special considerations for professionals. There isn't a lot of research on specific interventions and strategies to use for individuals on the spectrum with different mental health concerns. Part of that is the problem with they often don't fit under specific diagnostic criteria of depression and anxiety. So no one wants to do a study where they're like, well, we roughly said they're anxious, but we couldn't measure that exactly, or we couldn't use specific diagnoses. Part of that is just, it's hard. And, this is a special population. So there aren't a lot of studies out. But what studies have come out have shown that cognitive behavioral therapy tends to be the most effective for this population. Now, you do need to modify it. Individuals on the spectrum tend to need things that are more concrete or visual. So when you're talking about a lot of the metaphors that are used in CBT, that doesn't mean you can't use them. It just means having a picture of the metaphor is much easier. For a lot of my individuals, I talk about how, your capacity for understanding emotion is like a cup. And therapy can make your cup bigger so that you can deal with more stress as it gets pulled in. Coping skills empty out your cup in a safe way. They take the liquid out so it doesn't overflow. What happens if we don't grow the cup and if we don't take stress out? The cup overflows. That's what a meltdown or an outburst is in. I'll bring in a pitcher of water and a cup and make a mess on the table to show them. And we'll talk about, when we practice a coping skill, we'll talk about, okay, how much liquid did that take out of your cup? Was it a little bit? Was it a lot? Do we think we can make it grow? When we learn, some basic self-care routines around having better sleep, having better eating, exercising more. Ooh, let's talk about how that makes your cup bigger. So that helps you deal with stress and things like that. You also want to make things part of their routine. So as much as it can be difficult to have anyone practice their CBT homework outside of a session, you really want to help individuals on the spectrum locate, all right, you want to practice your deep breathing 3 times a day. Let's pick specifically what times a day you're going to practice them. Where are you going to be? Should we set an alarm? Is there a friend or a parent or a roommate that can practice it with you or remind you? That kind of thing. You want to build it into part of their day. And that's one of the strengths of individuals with autism, is a lot of times once something is part of their routine, it's not going anywhere. So if we make doing those sort of person building, that cup building and growing coping skills part of their routine, they're going to stay there. You also want to build in natural and purposeful rewards. So one of the benefits towards not losing our top and yelling at our friends every time we get angry is that our friends want to hang out with us more. So you know what? If you don't have any arguments with Johnny for a whole week, I bet you could ask Johnny to meet you for a movie on Saturday, and he'll want to do it because you haven't yelled at him in a whole week. That kind of thing. We always want to set specific goals and measure progress. Because individuals on the spectrum are so unique, have such different profiles of ability, we want to make sure that we're making things appropriate for them, that it's important to them, and that they can see their progress, again, in a very concrete way. That can be, last week you had an outburst every single day. This week we want to have one good day. Okay, that's our goal. It's not we want to go from 0 outbursts to, or rather from 7 outbursts a week to 0 outbursts a week. You want to do the small steps. You also maybe want to reinforce more often. So instead of saying you get a huge prize after a good week, you get high fives and hugs and stickers each night you don't have an outburst, that kind of thing. And don't be afraid to make adjustments. That's part of, especially the professional's role in this, right? Is that you're going to be the scientist looking at everything and adjusting things as needed. Saying, okay, that didn't work for you is an okay thing when you're working with the population. We're not going to know from the onset what works and what doesn't. And then, of course, we need a full team approach. The more people the person with autism has helping them through it, the better. Even with my adults that live independently on their own, that are working in the community or going to school at a typical college program, I still say, who is someone that you want to share your successes with, even if it's not someone that's going to call you and remind you to do your coping skills. If someone has a larger team than that, if you're working with an adult in the group home, you're going to want to pull in nurses, their behavior specialists, whoever else they're working with, and make sure that there's consistency across different settings, across different staff working with them. So that goes across all individuals with autism spectrum disorder. And what differs is who will be on their team. All right, now I see a few questions in the chat box. For anyone that's been waiting, please feel free to dive in there and ask your questions. So I'm pulling up the chat box so I can see what people are asking. All right, I'm trying to pull it. There we go. Okay. So we are going to be recording it and posting it on our YouTube. That was one of our first questions. Let's see. So how do you encourage clients to move on when they're perseverating and refusing to move on from the situation? Excellent question. So first I'll look at what kinds of situations they're perseverating on and try to get to what is sort of the root of that perseveration. Is it just a pure perseveration in terms of it's something they're super interested in and intrigued in? And can we give them an appropriate time to think and talk about that and not? So for example, I have a young lady that really likes to talk about Alice in Wonderland. But if all she talks about is Alice in Wonderland, inevitably someone will tell her to stop, and that person will have more or less patience as her persistence goes on. And then we end up having an outburst because that person has repeatedly told her to stop, and that is what is upsetting. So we've made visual cues. A laminated card that on one side had Alice in Wonderland, on the other side had a stop sign. This is when it's time to talk about Alice in Wonderland. You flip it. This is when it's not. And you start with, most of the time, the Alice side is up, and slowly give more and more time to the stop side. You're also going to want to tell individuals with autism, especially if you're trying to focus on stop this problem behavior, what is the alternative behavior to do? So as she responds more and more to flipping the sign, I might put, instead of a stop sign on the other side, other things to talk about that are appropriate, or pictures of the people that are with her to let her know, okay, you talked about Alice, but now it's your sister's turn to talk about her favorite thing. And now it's your turn to be a listener instead of a talker. If they're perseverating on worries, then I would do more of an approach of, let's focus on, all right, if the worry is it's going to break, it's going to run out of power, I'm not going to have it anymore, what's the positive self-talk that can replace that? I have my charger with me all the time. It'll be okay. If my iPad runs out, I have my favorite book. I can always read my book, to give them sort of replacement worries to think about instead. And then again, reward, reward, reward when they do that. Even if they repeat it once before they go back to the perseveration, at the beginning, that's great. That's still an improvement. Okay. So now I think we're going to look at the next question. So this says, for my clients that are perseverating on a situation that happened 3 years ago and they can't get out of the cycle. So it sounds like that keeps happening over and over again, right? Maybe, and I have had a similar situation where, and he comes in and he says like, yeah, I've had a lot of conflict with my parents. And I say like, oh, what happened? And, a year ago, my mom said this thing that was really mean. And so how do you dive in when it's a year ago? Okay, well, what did that mean? And then, what was the mean thing she said specifically? Oh, she said this, and what really upset me was she wasn't being understanding. And that's where, just like anyone else in counseling, you're going for, okay, once out of 25 years your mom wasn't understanding, it's almost like your mom's human. So that happened. How can we get better from that? And working on, all right, so she wasn't understanding that one time. Like, it's okay to be sad about that. It's okay to be angry about that. But we don't want that anger to stay with us. So how do we feel better when that happens? How do we, what coping skill do we need to do every time that thought happens in your head? Every time that thought happens in your head, you're going to say, it's okay, people make mistakes. I make mistakes too. And then you're going to do something you love. I'm going to go watch my favorite video on YouTube. It's going to make me laugh. And it's just about that re-exposure to feeling better despite that perseverative thought and moving on from it. All right. Got some text-heavy questions here, so I'm just going to take a minute to read that. Okay, so I have a question that says, I live in a rural area. My child is engaged in mental health counseling, but it's hard to find mental health counselors in my area. Do you have any suggestions for providers or what to look for in a mental health provider? So I think what makes a good mental health provider for an individual with autism is their ability to be sort of as flexible as that individual might be rigid or might be restricted, right? So for every individual that comes into my office, even though I specialize in autism, I don't know what that individual with autism is going to be like until I really get to meet them. So you want a mental health counselor that feels comfortable saying, I don't know for sure, but we're going to try it. And if it doesn't work, we're going to try something else. And if that doesn't work, we're going to try something else. It does require a lot of reading about what works for autism and what works for anxiety, and then putting together, okay, so what is the same across those things? So that's going to work with this person with anxiety and autism. Or, all right, that works for most people with anxiety, but actually that doesn't really work for autism. So how can I adjust it? How can I do it? So I feel like you're going to want a mental health counselor or provider that talks about problem solving creatively, with being flexible on trying different things, with monitoring their progress. I also try to focus on providers that really focus on having a goal, not because they want to get you in and out when you meet their goal, but because they want to be self-evaluative of their own work with you. Because, I'm not going to keep banging my head against the wall. I want to make sure that whatever works for you, that it is working for you, that it's working for my patient. And so that's where I would really push and really go for. And someone that's comfortable doing offbeat, weird things. The first time I suggested to a patient that was freaking out in the middle of session that, we're going to get up and we're going to wash our hands because you like water. That was a weird thing to do, but it really worked for that individual. So you want someone that's not afraid of being as unconventional as our population can be. All right, let's see. Pulling up some more questions. Okay. So I think I answered everybody's questions that we got through the Q&A.
You can feel free to unmute yourself and ask a question verbally as well if you'd like to.
We have one message. Okay, what is the best approach to support a student diagnosed with ASD and in addition has a significant history of trauma? He demonstrates many aggressive behaviors and also some behaviors that appear to be oppositional. He has language but can be limited in his ability to verbally communicate. So, great question. In the classroom, again, I think you want to do like a whole classroom approach to feelings are okay. We need to express our feelings appropriately. So that's where if you have a student, I often encourage having like a feelings card that's taped to their desk. I encourage you to put that student near a teacher or an aide so that they don't have to go far or draw a lot of attention to the fact that they are pointing out an emotion they're feeling. You want to provide coping skills in their desk. Now, as a teacher, of course, I encourage coping skills that can be done that don't necessarily detract from their attention in the classroom. That's where fidget cubes can be really great because they're small handheld things that give some nice sensory information that can be fidgety, as I just said, which is good for kids that are anxious and allows them to kind of play, but they don't have to look at it. Not like a fidget spinner, which I don't advise in classrooms. They don't have to look at it. They can just play with it in their hands and still look at what's happening on the board. I want to encourage you to let that child ask for breaks and space as much as possible. In terms of the trauma, that's going to be more about once he gets upset, being really careful in your approach. Trauma tends to make individuals feel threatened more easily in general, when you have trauma, but especially kids on the spectrum. And so you want to make sure that when you're approaching that child, if they're starting to get upset, you're approaching in a way that's gentle. I always remind, especially teachers and direct care providers, if they're starting to raise their voice, you're going to start whispering because that shows I'm not yelling over you. I want to hear you, but we're going to calm down and we're going to whisper and we're going to bring it down a notch. Sheltering from them from the views of other kids can be really important here. Being able to pull them out in a safe way or have the other kids leave in a safe way. It's not the responsibility of the teacher to do the actual trauma work there. That's going to be someone else's responsibility, but always providing that you are safe here. It's okay to be upset. What's not okay is when you get aggressive when you're upset. So as soon as you start to feel sad, let's identify that. Let's do something to feel better. For those of you that know the incredible 5-point scale, that's one of the things that I encourage teachers to use a lot. If 1 is, I feel great, I'm learning, I'm listening, and 5 is, I've lost it, now we have to call mom or we have to get sent to the principal because we're out of control in the classroom. I want you to tell me as soon as you're at a 1, not once you get to 5. So really helping the child identify what are their earliest signs, noting as someone that works with them all the time that knows them pretty well, what's the very first sign this isn't going to be a good day? Let's do something immediately. If he's coming off the bus and you can see it on his face, let's do a fun activity that everyone's going to enjoy. And again, you don't have to target that child. You can say, you know what, today feels kind of like a grumpy day. I need to do something fun so I don't feel grumpy. Let's all listen to music if you know music is something he enjoys. I know that teachers often can be limited in how much flexibility they have in the classroom, but if you think about it, listening to a song that's going to start him off on a better foot for 5 minutes instead of losing 20 minutes of instruction time because now you're dealing with an outburst, that can be quite worth it, and hopefully your administration will feel the same way. But definitely if he has a hard time verbally communicating, sometimes on those feeling cards too, I'll put the 4 feelings on one side, and on the flip side, I'll have a coping skill. So they can show me I'm angry, flip it, I want to blow bubbles. Great, let's do it. You didn't even have to talk. We're going to get the bubbles. That kind of thing. All right. Any other questions? Okay. Well, it's been a real pleasure talking to everyone. As we said, this will be available on our YouTube. I do want to point out, just go back over here, that I did have a few references from different studies about co-diagnostic rates and things like that. And if you like some of the positive doodles, that is Embroy's artwork. She makes really adorable doodles. And sometimes in those positivity scripts, like I have a kid where their positivity script is just a book of her doodles because he loves her artwork and he colored them all in and he really likes having her words instead of his. So feel free to indulge in those too.
Thank you all for being here today. I'm going to go ahead and send a survey out just to collect some feedback on how this webinar went and any suggestions that you guys have for ideas going forward. So please respond to that if you get a chance. It's super quick, super easy. So that will go out in just a little bit. And let's see, it looks like we have another comment. Yes, Tiffany, can you ask it in the chat box? I can try finding you and unmuting you. 1 second. Okay, you're unmuted, so you can go ahead and try talking.
Hey, thank you, because I'm trying to share. We're trying to share. This is okay. So this is Tiffany Carr from the Easter Seals Diagnostic and Treatment Center, and my human therapist is sitting in on this webinar. I have a question. When you were talking about anger, I hear an echo, Lord have mercy. But when you were talking about anger, a lot of the symptoms you were outlining mimic an explosive disorder. Can you talk about a rule out with folks on the spectrum?
That's an excellent question. So in case anyone else couldn't hear the question, it was talking about ruling out intermittent explosive disorder for individuals with autism that also have difficulty with anger and irritability. So in general, when I'm working with individuals on the spectrum with illness concerns, I want to think about, all right, do I need to add another diagnosis, right? So intermittent explosive disorder in itself doesn't necessarily tell us any more about psychopharmacology. It doesn't tell us any more about how to engage in therapy or how to do coping skills. There isn't a huge body of research either on what helps them. And so does adding another label and another diagnosis really add to this individual's treatment? Because you're absolutely right. That is going to be a really hard one to pull apart. So I would more think about, is this going to benefit in any way? Is adding that label to that individual going to benefit them in any way? And what I would look at more than, should I diagnose it right away or not, is as I'm working on it, as I'm improving it, am I only seeing anger and irritability around triggers that are common for an individual with autism, rather than this is really intermittent explosive, it's coming out of nowhere, right? Because for an individual with autism where they get explosive every time their rigidity is interfered with, or every time there's a transition, or every time there's a change, that's more of an indicator of someone with ASD and anger or irritability rather than intermittent explosive. So I would look at the progress, at the process for the individual. I definitely wouldn't jump and try to put that in there right away. And then in general, I would look at, is that diagnosis going to be helpful, going to be informative? Now I know in general, we want to add things like this person has anxiety, this person has depression, this person has anger problems, so that providers working with them so that everyone getting their medical record has that information. But I think we can add descriptors like that without necessarily adding another diagnosis and another label.
There's one more question. Right here. Did you see this?
Can you recommend some resources for adults 40 plus with ASD that are similar to those for kids? There's a gentleman on my caseload who is in the process of moving into his own apartment, but has never really had appropriate supports. I'm looking into community hab, but am not sure where to go in terms of supporting his diagnosis. So I think I'm not quite sure what kind of supports you're looking for in terms of, like, are you looking in terms of emotion, like mental illness and him supporting himself in a mental hygiene sort of way? Are you just looking for general community supports? And we can look for Shayla and unmute her, or we can see if we can, general community supports. So a lot of that is going to depend on your area and around you. On the self-direction, and I can, we can probably add that to maybe like the email with the survey, but like the self-direction website has a lot of good supports and descriptions for adults. What is it called? I think it's called like In the Driver's Seat. Mm-hmm. So if you Google like In the Driver's Seat, OPWDD, that will come up with quite a lot of good resources for adults in the Rochester area.
The name of the YouTube channel is Pediatrics URMC, and we post all of our webinars there, but we will be sending it out in a link to all of those who registered for this webinar, so you'll have it that way as well. And we'll also put it up on our Regional Center website page, so it will be available in a few different places.
Okay, so I see, what is a good resource for individuals with high behaviors and mental health? So if by high behaviors you mean aggression towards self and others, again, this is, you're going to want to teach the same things with emotion regulation and coping skills. You're just going to want to use kind of like the tiniest tests and support to build up success. In general, you want to focus on safety and helping them feel safe, helping others feel safe. So first, you're going to want to bring down as many triggers as you can so that while they're learning to use their emotion recognition skills and coping skills, they're in the least amount of stress possible. And then you can slowly add stress as they gain skills, as they gain confidence in their ability to use their skills.
Any final questions? You can feel free to unmute yourselves and ask, or write in the chat box. We have about 10 minutes left, but we can always wrap up early if there are no more questions. We'll give everyone just a minute or so. Okay, well, it sounds like, oh,
you're welcome.
Yes, thank you so much to our wonderful speaker, Dr. Leona Oakes. She did an amazing job, and we're so grateful to have such expertise around autism and mental health. So we will definitely be sharing this webinar, and once we send you the link, feel free to pass it on to anyone who you think would find this information helpful. I know there's a lot of gaps in the resources available in this area, and we really want to make sure we get this information out there because it's a need. So thank you for being here today. We're going to go ahead and wrap up, and you can, is there any place they can find resources for you or get in touch with you? Your email, is that the best place?
Yes, absolutely. Let's throw my email in the chat box. Yeah, so it's just Leona_Oakes. Oakes does have an E at urmc.edu. Let's make sure I spelled that right. There we go.
Okay, so feel free to reach out to Leona if you have any specific questions or ideas on how we could get more information on this out there. Okay, everyone, thank you for being here. We're going to go ahead and wrap up, and I hope you all have a lovely weekend wherever you are. Bye.